Hey everybody, Dr. Sloan. Just a quick overview of electrolytes. We'll talk about this way more in class. So remember how we talked about homeostasis with acid-base balance? Well, this is part of the process, is using electrolytes to help achieve acid-base balance. And again, electrolytes are very essential to homeostasis. And homeostasis just being that process of keeping your body in its happy place, right? Keeping all of its fluids where they're supposed to be, pH where it's supposed to be, oxygen where it's supposed to be, excretion like it's supposed to be. So again, we're homeostatic um, creatures, and the electrolytes are part of that system. So they're primarily responsible for a lot of nerve and muscle contraction, water balance, and bone growth. The most important imbalances for humans are related to sodium, potassium, and calcium. And actually, we're not going to talk about calcium in this lecture because calcium is usually talked about more as it relates to drugs for bones, like drugs for osteoporosis and even drugs for thyroid diseases. So we are not going to talk about that. So imbalances can be caused by nutritional issues, drugs, and water balance. And that is like a huge oversimplification. If you're going to have damage to tissues from a trauma, there are other things that can cause imbalances. But I would say nutritional issues, drugs, and water balance are kind of the big picture. And then treatment of these imbalances really depends on how severe it is. So if it's not that severe and you're just maybe getting a muscle cramp here and there from your hypokalemia, no big deal. You're going to go ahead and do probably some oral replacement. But if you are down in a danger zone with your potassium, let's say, and you're having cardiac symptoms, then we're going to want to correct that really quickly. So one thing I'll say about electrolytes, though, is they are not to be given like vitamins, right? Vitamins, a lot of times we'll say things like, well, if your body doesn't need them, it'll just excrete them. That is not the case necessarily with electrolytes. And electrolytes that we drink is one thing, right? Our body's pretty good at filtering that out. But electrolytes that we put into someone's bloodstream with an IV catheter, that's much more difficult for the body to regulate if we mess up, if we give too much. The balance can go from hypo to hyper really fast. So we have to be really careful when we give replacements. Osmolality slash tonicity. They are close in definition, but for the most part, we talk about tonicity in nursing. If you're going to work in the ICU and you're going to work with patients who have, head traumas and stuff, you may get more into osmolality and be looking at that. But we're essentially looking at tonicity. So tonicity helps us understand how fluids are shifted from one space to another in the body. So whether something is hypotonic or isotonic or hypertonic, if you think about that, if we put any one of those three in the blood, based on how much sodium is in there, we can actually have these fluids lead to fluid shifts, which could be good or could be bad. But we're always trying to use them therapeutically. So fluid movement, we'll again talk about this more in class, but I think you can see here that when we're talking about fluid movement, we're talking about movement between plasma and interstitial fluid for the most part. Now, interstitial fluid can then go into intracellular fluid, right? But the biggest issues that we have are fluid deficits and fluid overloads. So for instance, if you are completely overloaded on fluid, let's say you got 4 units of red blood cells. Well, in addition to red blood cells, you're getting, the plasma, which has water in it, and you're getting albumin and other things. But sometimes that can really overload a patient. 4 units of blood would be 2 liters being given. And let's say in a trauma situation, we're like, yeah, we want to give them blood, but we don't want them to be totally overloaded, cardiovascularly. So we might follow that up with some Lasix, right, to offload some of that water. So we'll talk about that a little bit more. So sodium and potassium are the two electrolytes that we're going to talk about. And sodium is the most abundant cation. Remember, it's a cation because it has a positive charge, and anion has a negative charge. The most abundant cation in the extracellular fluid. So all the fluid outside of the cell, which is the interstitial fluid and the plasma. And we can also use blood as sort of a interchange for plasma. It's just that when we say blood, I think in this context, some people think, oh, blood cells. And we're not really talking about getting fluid into blood cells, although that's a whole nother thing as well. But really, we're talking about getting fluid into the blood vessel or out of the blood vessel. So plasma, blood, we can use them kind of interchangeably in this discussion. So sodium is the big extracellular one. And then we talk about here intracellular and extracellular. I absolutely love this little diagram right here. What's kind of interesting is it talks about how intracellular fluid is 40% of body weight, extracellular fluid is 20% of body weight. And that's true, for most people. What it doesn't talk about is that when you look at like little kids versus adults, little kids are like 80% water, whereas bigger adults were more like 40% water. So little kids, think of them as like soft and juicy. They have soft skin, they're squishy, they're fun to hold. And that's, they have a lot more water than we do. And that's because they are not fully grown and they don't have bones that are fully developed and organs that are fully developed. And so they're high in water content. But it also should help you remember that it also makes them very prone to dehydration. They can dehydrate very, very quickly. Okay, so sodium, again, we're going to talk about this in class, but sodium, I think most people can think about this like it makes sense to us, right? Hyponatremia and hypernatremia, but it's usually either excessive dilution of sodium, and we see that quite a bit in people, especially if there's certain underlying conditions. But you could also have excessive sodium loss as well, like a burn or something like that, where there's just huge amounts of fluid loss occurring through open skin. And then hypernatremia, this is failure to excrete most often. Excessive intake of sodium, yes, you probably, you can definitely do that with food, but not to the point that you're going to make yourself hypernatremic unless your kidneys aren't working. If your kidneys are working, it's going to dump that sodium. But, before it does, it's probably going to raise your blood pressure and cause some other issues. Um, so hypernatremia is hard to do from a dietary standpoint. Okay, potassium. This is the most abundant cation in the intracellular fluid. So potassium needs to be inside your cells, right? And it helps with acid-base balance. It also helps with intracellular function. That makes sense because it's in the intracellular fluid. And it helps, remember that whole sodium potassium pump thing, but it helps also too with like nerve conduction and muscle or cell function. So hypo or hyper K is associated with fatal dysrhythmias of the heart and neuromuscular disorders. Hyperkalemia, this can happen due to drugs, like maybe you're taking a potassium sparing diuretic. And so now your body's hanging on to too much potassium. Um, and then sometimes you might have the failure to excrete. Again, maybe you have a kidney issue. But we can correct hyperkalemia usually with polystyrene. It's a drug that is frequently referred to. Its trade name is Kxalate, and it can turn hyperkalemia around really quickly. But you can also reduce dietary intake if somebody's got high K. Again, how much you can impact their potassium level with dietary correction is, probably minimal, which not to say that it's not important, but it's not something that you would do for rapid. Hypokalemia, this is another one that we get concerned about. I probably in my practice have seen more hypokalemia than hyperkalemia. Hypokalemia is more from high doses of loop diuretics, poor dietary intake, high physical activity, vomiting, and it affects, again, neurons and muscle fibers. So you can treat, mild hypokalemia with dietary things like foods, nuts, avocado, lima beans, bran cereals. A lot of people say bananas. But if you have significant hypokalemia, clinical hypokalemia that is causing problems, then probably going to need to infuse potassium via the IV fluids or through an IV supplement where you're actually like bolusing potassium itself. It requires very careful monitoring, again, because of its effect on muscle fibers, specifically those of the heart that we're concerned about. Okay, and the last is calcium. And like I said, this is related mostly to bone growth and bone absorption, so not something you need to know right now. But I did want you to know that of the three electrolytes that, are most important to our physiologic function, not to say that things like, calcium and magnesium, those are more, magnesium and, oh my God, what was the other one I was going to say? Anyway, those will be talked about later when we talk about nutritional deficiencies. So calcium, sodium, potassium, those are the ones that we get most concerned about. And we're just going to focus in class on sodium and potassium. Okay, that's it. I look forward to seeing you in class.